Hello, everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Saxe Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Intra-Hospital Transport of Critically Ill Patients, How to Keep Them Safe. And now I'd like to introduce you to Tyler Weiss, who is our moderator today. Tyler is currently the clinical specialist and supervisor in the Department of Respiratory Care at Rush University Medical Center in Chicago. At Rush, Tyler serves on several leadership committees, including the Chronic Care Illness Team. He has received several certifications, including Asthma Educator, Adult Critical Care Specialist, and Advanced Cardiac Life Support Provider. He has been awarded Outstanding Clinical Educator at Rush, as well as presented at numerous medical conferences. Among all of his numerous activities, Tyler is also pursuing his doctorate. Tyler, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Good morning, or afternoon, depending on where you're tuning in from. And thank you, Emily, for that very kind introduction. The title of today's webinar is Intra-Hospital Transport of Critically Ill Patients, How to Keep Them Safe. Speaking today on this very timely topic is a colleague of mine, Dr. Sheila Whalen. Dr. Whalen is currently the Clinical Integration Program Manager at Rush University Medical Center in Chicago, Illinois. In this capacity, she acts as the liaison between clinical operations, nursing, and information systems for the acquisition and implementation of technology. Dr. Whalen is responsible for the optimizing of physiological monitoring systems, including implementing new systems, recommending changes in workflow to improve the use of monitoring technology, and determining where there are gaps in technology. She is involved in several professional organizations that promote the better use of technology, including the task force leader for the National Coalition to Promote the Safe Use of Complex Healthcare Technology and the Association for the Advancement of Medical Instrumentation. I would like to note that our speaker has disclosed no conflicts of interest associated with this presentation. And this webinar has been accredited for nurses and respiratory therapists. It has been approved for 1 contact hour. There will be a link to obtain CE credits at the conclusion of this webinar. Here is listed the accrediting bodies, and we'd like to thank you, Phillips, for supporting this educational activity. And at this time, I'd like to turn the webinar over to Dr. Whalen. Dr. Whalen, are you ready?
Thank you so much, Tyler and Emily, for your kind introduction. Yes, I am ready, so let's get started. So today's learning objectives are at the conclusion of this session, you will be able to discuss the importance of stakeholder engagement in the design and implementation of seamless patient monitoring during transport. Explain challenges and strategies for the transformation of healthcare data into information and knowledge for intra-hospital patient transport using hospital wireless networks, data workflows, and standards. Lastly, describe the best practices for the seamless intra-hospital patient transport to ensure patient safety and data collection. So our outline today will identify the risks and provide a workable framework to ensure that patient safety. Strategies include that stakeholder engagement, the benefits of standardization, the importance of a wireless assessment, and testing to ensure those alarms, trends, and waveforms will continue to be tracked and integrated during your transport. And finally, explore the current literature along with a case study to illustrate the challenges and best practices. So, when it comes to intra-hospital transport of critically ill patients and keeping them safe, what is the problem? And I like to use this in many things that I approach when it comes to dealing with challenges that we face in organizations with dealing with patient care. And before you enter into finding a solution, you really need to clearly identify what is the problem. So I wanted to remind all of you of that. And the worst thing that you could ever do is go ahead and try to automate a problem that you thought was the problem, and then you come to the end and realize that you didn't really accomplish what you had hoped. So just keep that in mind. What is this problem? Well, the problem really is keeping our patients safe, and so the standard for intra-hospital transport is to provide that same level of care, requiring connected physiological monitoring as if they were still in the ICU. So when you have it, what are some of the impacts for this intra-hospital transport? Well, if any of you have ever had to do this, I have in my past, and I still support some of these today. There's two major factors. There's the environmental side, and then there's the patient side. So on the environmental side, you really are concerned about you're leaving the protection of your critical care unit. So you have everything that you need. Is the equipment portable? Do you have everything that's required for that patient? Are all the personnel who are going to be supporting you through this journey with the patient, are they trained and ready? What is the impact on the staff who remain within the unit? Because depending on your patient and the load back in the unit, it's going to put an impact of having less staff. How far will you have to travel? What is the time frame that you're taking this patient? A time of the day, could be how long it's going to take, things to that nature. And lastly, that wireless connectivity to the central station for data continuity. Although you would still have the ability to have the patient monitor alert and tell you when there's issues along the way, it's very comforting to have that information being tracked back at the central station within the ICU environment, and as well as having the data to review if needed and to have it enter into your electronic medical record. So on the patient side, changing this patient and moving them is going to cause some physiological changes, and they typically land in these four categories: for respiratory, cardiovascular, neurological, and their temperature. So our job as the caregivers is to do what we can to protect the patient in those four areas. So what are some potential mishaps? Well, once again, similar to the last slide, we have system-based mishaps as well as patient-based. So in terms of the system-based, the human factor is that you may have somebody going off on a transport that has inadequate training. There may be inexperience leading to patient instability or harm, and then there could be challenges with communication that could cause a delay. In terms of equipment, when you've gathered all the equipment available, be assured that could there be a battery failure? What if the monitor has a malfunction? What if you disconnect from hospital wireless? Would there be any cable issues? Would there be a depletion of portable oxygen supplies? And what's not on here, maybe you need to bring a portable ventilator. Is the staff ready and to go when it comes to that? In terms of our patient, you always have to do a check. Are they ready? Physiologically, is there any deterioration related to this diagnosis that would put the patient at a higher risk for problems to transport them? So it's always good practice to do another quick assessment before you take off. Are there any changes in acuity that could be increased need for diagnostics off test units? Do you still have to continue to do these things? And is there a way maybe if you can't leave, the test could come to the patient? So many times these things are emergent or they could be planned. So here's a review in terms of systems for adverse events. At the top of the list being airway, could they be extubated? Could they develop an obstruction? Would there be an aspiration? Breathing, could there be even something worse, a respiratory arrest, hypoxemia? Down the road, could they receive a ventilator-associated pneumonia or a tension pneumothorax? In terms of circulation, their BP could fluctuate and can include even severe hypotension. They could experience an arrhythmia or, worst case, a cardiac arrest. With neurological patients, they could experience increased intracranial pressure, get more agitated, and their temperature could change. So I found this from a really nice article, and I thought they did a beautiful job summarizing some different adverse events and an intervention in the summary of that. So you can see on your left about the top one is hypoxemia. hypoxia and hypotension. And those things I've actually experienced myself when I've had a patient go on a transport. And it is so important on the intervention side, as you can see, just to have that oxygen nearby. Do you need to have a vasoactive agent? Is there somebody else who can help provide any other support to you in terms of any technical or fluids or anything to that nature? Have the medications on board. So it's really nice to know that you're surrounded with folks who can help you as well as equipment. So those interventions is what you plan for as you prepare for your transport. Before you embark on something like this, having a multidisciplinary approach is really key, and having those stakeholders at the table throughout your process. When you are going to go ahead and design a new way of doing this at your facilities, or you're evaluating maybe there's a better way to do it, it's really nice to have all of these folks involved. From the executive sponsor to who could be in nursing, it could be somebody in the IT side, it's a variety of people, nursing leadership, providers, respiratory therapy, patient safety, risk management, quality, as you can see. One of the unique things that we have experienced here too is a performance improvement specialist. They can give you an insight of things that you just aren't seeing because you've been doing it for so long, and they can help you map things out. And then get the stakeholders who actually are at the bedside, who are going to be using the technology and going to be taking care of the patient. And then lastly, the clinical engineering team and information technology team, and potentially your vendors who could be partnering with you during this journey to make sure there isn't issues with your wireless or the equipment that you're using. Some of the other places to look for guidance, I would say, is the resources you see here listed. The Society of Critical Care Medicine, the American Association of Respiratory Care, and lastly, the Agency for Healthcare Research and Quality. For guidelines to know if your patient is good to go, as I mentioned earlier, to assess that patient, some of the things that we have seen to be helpful is really understanding what is going on clinically with that patient. So checking how is their pupils, what's going on with their neuroassessment. Are their vital signs the same? Are they stable for this patient? If they are also have ICP, how is that impacted at this point? How are things going there? What's their pain? Did you pre-medicate them? Is it possible to do that in enough time? Make sure that all of their catheters and tubes are patent in the event that you need to use them. And then if it's a spine patient, be sure, as you would all know, to make sure that they're immobilized and that they'll safely be able to handle the transport. So some of the recommendations that we see is really complete a transport process map with that performance improvement specialist. It's invaluable. It does take a lot of time to get the stakeholders engaged and to find the time in their schedule to do this, but I can assure you that it will make a difference. It'll uncover things that you didn't realize existed, and it will be able to form an environment for new ideas to be brought forth. Then once you've done that, really focus on writing a protocol and procedures to give guidance for those of the caregivers that will be coming along who are maybe new to this organization that you work within, or just new to the idea of transporting patients, so that they feel more prepared. Evaluate that pre-transport readiness, meaning the equipment, yourself, and the patient. Communication and coordination is key between teams. I know that the Joint Commission has even found in many of their Sentinel events, communication has been part of the challenge with that. So communication is key. What are your monitoring requirements for this particular patient, and what's the standard throughout the hospital? And keep in mind that you are trying to still create the ICU on the go experience for this patient. What personnel is going to be required? Are they there? Are they ready? And then the training and simulation, it's always a good idea to go ahead potentially yearly just to review this with new hires. If you have a simulation center, you could try that and use it as a best practice. So I love this table in that it talks about the many why questions, who, what, why, all those W questions, and they really are helpful. So in terms of why is this transport necessary? Ask yourself that. Do we really have to do this? Is there any alternatives? Who is the patient, and who can accompany the patient? Are there any handoffs required? What equipment? We talked about that. What do you need? When? What time is the procedure happening? Are you going to have the best timing if you have another patient assigned to you, or within the unit if there's a busier time is something that you need to be aware of. And where are we going? What is the best route that we need to take? And would there be anywhere along the way that if you need to stop for help that you'd be able to do so, and everything would be safely cared for as you go on your path? So wireless coverage assessment. So some of you who are not technical may not be familiar with this, but there's an international guideline that talks about standards for wireless and wired healthcare networks. And I found that this is really invaluable for hospitals for guidance because they need to understand what are the risks. So this is a way to have the application of risk management for IT networks that incorporate medical devices on them. If they need to also identify roles, responsibilities, and activities that are necessary for risk management of the IT network, incorporating medical devices to address safety, effectiveness, and data and security. It's key to review the wireless coverage required for this patient's monitoring experience. What are the transport paths that you would be going on? It is helpful if you can minimize that to keep it simple and just have one key transport path if possible. Once you've determined that, perform a wireless site survey. And it's recommended that you would have maybe a third party come in to do that. And in our experience, we did that. And then we also had they partnered with our own internal engineering team, and we worked with our vendor to ensure that all the best practices were put in place and all the boxes were checked to ensure that during that transport, and maybe where other patients are ambulating, that they are still connected to our wireless. Implement adjustments as needed to improve that performance. You still remain connected and eliminate any potential signal loss. And of course, before you go on any type of trip and you're doing any type of assessment, you need to do some testing. So plan to do that testing maybe more than once prior to your actual go live of using your wireless system or implementing your patient monitoring system. So like I said in the last slide, trust but verify. I think that you can't go wrong by always trusting and verify. So approach it like you're administering a medication. Check 3 times. You want to check that this test system was verified. When you did the test, everything was good. Then review the wireless monitoring locations again. What is the need? Walk that transport path with a connected wireless monitor, and also have somebody back at the hub where there could be a central station so they can verify your connectivity. Do they see that waveform during the transport? Are the vital signs still flowing? Are they hearing any alarms if you could simulate them, either visibly or audibly? What data elements are being captured during this transport? You should be seeing full disclosure, alarm strips and trends, and there should be a way to understand how is the battery. And depending on which device that you are able to bring with you, you may need to pack in your little goodie bag an extra battery in the event that that battery would die. So both on the actual devices themselves and then back at the ICU station, you can check those types of things. So always trust and verify before you go off on your first adventure with the patient. So standardization really helps save lives. If you can do this, and the benefits would be it can be repeatable, it's reliable, it will ensure your patient's safety, it'll ensure your clinician's safety, and it will allow everyone to focus on the patient and not the equipment. So here's an example of a case study, and it is an open heart patient who could be coming from home, and they are admitted to the pre-op area. Once admitted, placed on a patient monitor for a quick check on their vitals, then they are transported into the CVOR for surgery. Once that is completed, they will remain on that same patient little transport monitor and then be transported to the ICU. So this is a crazy busy slide, but it just goes to show you all the complexity of getting one of the simplest situations, a patient from the OR that happens on a daily basis, to the ICU, and there's many things that need to be considered. So I just won't go through each step of the way here, but it just gives you an understanding, if you've not done something like this before, there's many steps to go from point A to point B. So to simplify it, here's an example of how we tried to understand what the current state was and what would be our future state. So if you look at the top on the slide here, everything in blue in those boxes is what we had been doing. We would hook up a patient to the X2 in the operating room, and they would do the surgery. The OR nurse would then call in varying order to understand what's the patient placement, the transport, and where they were going, SICU. Transport would then pick up our patient's SICU bed and bring it down to the OR. The patient then would be transported to SICU, connected to the OR monitor. They would swap equipment in SICU, and anesthesia would be responsible to bring that piece of equipment, being the X2, back to the OR. Then the anesthesia tech would turn over the OR with the X2 from SICU or another OR. So we were finding some challenges with this story. So in working with our team and a process improvement specialist, we came up with a new future state. So the biggest changes were in green, as you can see here. So now what we're going to do is have the ORRN call in order and speak similar to what we saw before to the nurse up in the ICU. The SICU will then bundle and bag the equipment and place that on the bed. Since the bed was going to be going down to the OR, it really made sense to go ahead and place the equipment in the manner that they would need for that patient downstairs, and there would be an addition to a new thing called an audit form. The transport would then come pick it up with the bed and the bagged equipment. We bagged the equipment so that it would remain clean as the bed was sitting in the hallway and then moved into the OR. So that was our way of doing that, and it kept everything all put together. And then lastly, the anesthesia tech at the end there would verify equipment and turn over the OR X2 from the ICU. So here's an example of how we had that set up, and many times we may not be aware of how many pressures a patient would need, so we would come together as a team and decide we would send everything regarding what that patient's needs were after that conversation. And then you can see the picture here as everything's all bagged for transport so that the patient was ready to go with their ticket to ride. But before that would happen and the bed would start to go, in order for the patient to have that safe passage, their OR circulating nurse, we created a form, and these are the things that they would do. They would call our ICU charge nurse and provide the following information: the name of the circulating nurse, which OR room are they coming from, who is the patient, what's their date of birth, and who is the surgeon. The ICU nurse would then communicate with the OR circulating nurse and ask the following: the type of procedure, the estimated time of arrival to the ICU, would that patient be ventilated, and what would the needs be in regards to that? They would also continue to ask some of the following things, and you can see them all listed there. And I've highlighted number 3 in red because that seems to be one of the biggest challenges, is that do you have the proper cabling that you need? Because you can have your equipment, but if you don't have the right cable, then you really won't be able to get the information out of the patient into the patient monitor. So we found that one of our biggest challenges was the invasive pressure cables. So we do make sure that we ask that question. And after the patient arrives, what equipment is received? Was there anything missing? And it is documented. And then some of the other things there in terms of that patient status. So what is the benefit of a solution in this regard? Savings on clinical time transporting equipment for anesthesia. We have found in our experience, may be different than some of you out there, but our anesthesia team many times does not return back to the exact same place where they started. We have multiple OR locations, and they may need to go see a patient in a different area. So that has really helped us on saving time for them and the team that supports them. Very little workflow changes to the other teams if you have a solution that is, standardized. It helps that transport is already ready to go with being able to move beds. In this case, from SICU to OR, they bring the bed down. The SICU RN is already preparing equipment and cables to get going to the OR. The OR room turnaround time will be decreased. There is nothing worse than having the OR having a delay in terms of the cost. There'll be no waiting around looking for equipment, cables. It'll be ready to go and ready for that room to turn over. There'll be savings on damaged cables if we standardize the way that they're transported, and also standardizing the OR/SICU nurse report to include those monitoring cables that'll ensure an easy swap and reduce that clinical time looking to replenish cables. We have found that it could save up to 20 minutes based upon what cable they're looking for, either on the tech side within the OR or even within the unit. So some of the best practices that I would encourage is clearly having a policy and procedure is very important in evaluating, is it up to date in terms of the practice that you are also seeing in your facility. Continuing managing that patient with that same level of care, and be prepared to manage and change if that patient's condition has a change. What communication tools are you using? Do you have checklists? Are they helpful? Do you need to do something within your medical record? What is your wireless strategy? Evaluate it. Has connectivity throughout the coverage areas? If you decide to make any changes, in our facility we use the access points, and they have a lot of responsibility that have a heavy load, so you really have to always understand the care and taking care of those as well. If you add new technologies and have to test if you're adding new phones or something to that nature, how is it impacting your patient monitoring wireless connectivity? And create a standardized process. What is your pre-transport prep? What is your transport route? Is your equipment ready? The patient ready? And I would say a number 5 is, are you ready? You ready to go? So I like to look back in the past, and one of the founders is Florence Nightingale, and an inspiration from her is the very first requirement in a hospital is that it should do the sick no harm. So thank you everyone for your attention today. That concludes my presentation, and I look forward to answering questions from you in the audience. Before we begin our Q&A, Tyler has a few reminders.
Thank you, Dr. Whalen, for that great presentation. So here I would like to just remind you guys that this is accredited for nurses and respiratory therapists. The educational activity is approved for 1 contact hour. To obtain the CE credits, you'll go to saxetesting.com/BO. You will need to register at the site, complete the evaluation, and upon successful completion, you will be able to print the certificate of completion. Once again, I would like to also mention that this educational activity has been supported by Philips. And now we will move on to some of our questions. So I'll start off with one. This one's just a comment from Narina. Dr. Whalen, you talked about some of the resources and that we could use for transport. And Narina just wanted to mention that another source, a good source, is the Air and Surface Transport Nurses Association. So also check there. Next, we have a question here from Brenda. Brenda discussed how she worked for a short time for a hospital that was beginning to use telemetry instead of taking a physical monitor with a patient being transported. And her question is, do you feel it is necessary for the telemetry technician to have direct contact with the nurse doing the transport?
That's an excellent question. We do think about that here as well. And I think in our case, we don't have a telemetry person watching over, so we wouldn't have anyone really to be speaking with. But in terms of a hospital that would have that, I think it would be helpful. It depends on the type of telemetry device that you have. If that patient's sick enough to be warranted monitoring, you would want to be able to still see potentially what the ECG will look like. And in the event that you have a telemetry device that does not have a screen, and if the technician was going to be in contact with you to let you know that they are seeing an issue, then it would be helpful to have the ability to visualize that yourself. And so you may want to consider in that regard, do you need to see it visually? Do you need to do more for that patient. So I think it's a helpful thing if you do have a telemetry monitor technician, that they're able to be in contact with that person if possible. It would be a good practice. So thank you for your question.
Okay, thank you. So we have another question here from Michelle, and she actually has a couple questions, so I can actually put them all into one because they're all related. So she first wanted to just know if our facility did go universal with monitors, and her question was, what would be the most efficient and effective way to present universal wireless monitoring in her hospital?
Great question. Yes, we do have a universal platform, and I think that does help with the minimizing the complexity and creating a standardized process. It's something that we strive for here, and we have to cover quite a large territory, so multiple buildings, and we do have one single transport path for the patient. So that really helped us in terms of our wireless coverage, although our wireless coverage is throughout the facilities, because not only are you transporting patients, but patients can also be able to ambulate potentially independent, or a physical therapist may need to ambulate with a patient, and so they do need to be wirelessly monitoring during those events as well. But I would say if you could have a simplified approach by using the same standard and try to have the same monitoring throughout as your baseline, and then if you need to present this to the stakeholders within your organization, just keep focusing on the things that we had discussed in terms of what kind of need you have in your organization. How many transports are you doing? How complex is that transport? Keep in mind the goal is to keep that patient safe and feel that they're still within the ICU environment, and how having that wireless connectivity is really helpful in terms of potentially documenting throughout that transport. Some of these devices don't have a physical recorder on them, so by having that network connectivity, you're able to still capture events that would happen if in the event that they would have an arrhythmia and you needed to understand what happened to that patient before or after the arrhythmia. It would be easily able to be reviewed and potentially printed if you needed to use it as a learning tool. So there's lots of benefits in focusing within the patient safety aspect. You can never get lost as your true north and keeping that patient safe.
Okay. Another question here from Judy. She's wondering do we ever do debriefings after transport to improve or to get a better policy?
Thank you, Judy. Yes, we have done that, and that's what some of the things you had seen within the presentation. Our process still has room for improvement, and it's always nice to reevaluate if things are not working. One of the things that we're still struggling with is the cable management and how to manage cables, how we share cables. We're very good about sharing the equipment piece, but it's the cable piece that we still struggle with, and that part, because of that, costs a lot of money and still could impact our patient and time savings. So we still strive to make that better. And then things could change within your organization. You may have a new team that gets to be part of the story. If you have a new CV surgery team that becomes part of your organization or something like that, that they may have a new way of practice. So sometimes not only is it just the current practices that you're doing that you want to make some changes, but it could be new players within the organization, new stakeholders, or there's just another piece of equipment that is now being utilized. So I think always touching base and reevaluating is a good thing. And we found that at least if you don't hear anything, it's still important to double check how things are going periodically.
Okay, thank you. So we have a lot of questions coming in about recommendations for transporting ventilated patients as to preference of vent versus bagging and BiPAP. I have some input that I could give on that, but I'll field it to you first.
I'm grateful that you can also give your insight, because one of the things that I've experienced myself as I've had to go through that. I've had to bag a patient and it's very stressful. I like the idea of having a portable ventilator. I think understanding if your patient's intubated safely is really key. Can you measure end-tidal CO2 within that transport? That's a nice clear indicator how things are going. And if that capability is there, you should use it. And I will then again go ahead and Tyler, what's your insight on what your experience has been?
Yeah, so again, obviously having the transport vent is better. If you have the capabilities, obviously, especially if you're going to certain areas. If you're transporting a patient for MRI, you cannot sit and bag the patient in MRI or CT. So those typically you need a transport ventilator. Recommendations on ventilators, I don't have any. It's whatever one works best for your institution. Bagging patients, we typically depend on if we're taking a patient to OR, we usually use our PEEP and our ventilator settings as kind of an indicator as to if the patient needs to be bagged down or not. So if someone is having oxygenation issues in the ICU and it needs to go down to the OR, typically, PEEP greater than 10, FiO2 greater than 50% is kind of our threshold. We'll typically won't bag them down. We'll use our transport ventilator. But if they're on baseline ventilator settings and they just need to be transported down to the OR, bagging we typically will use. But those are my recommendations when it comes to that.
I have a question about that transport ventilator.
Mm-hmm.
Do you recommend a certain amount to have within a facility based upon the amount of transports that we would have that you would anticipate, or do you have them located within the ICU environment so that they're already there? And then how do you assess the battery?
Yeah, so our transport ventilators we have on our 11th floor, which is our neuro ICU, which has a lot of transports, and our surgical ICU. We have 3 transport ventilators for CT and anything else, and then we have 1 for MRI that's MRI compatible, and then we have on the 10th floor on our other ICUs, we have, again, 2 transport ventilators for CT or anything else and 1 for MRI. And so those are always plugged in, so the batteries are always fresh, fully charged, and we typically have enough for, to have 5 transports going on at one time would be interesting. And then we also have them down in the emergency room as well if needed. So yeah, we have them located right in the ICUs down in the ED where we would probably need them most.
And how do you communicate with the other respiratory therapist? If do you need to let them know you took one?
No, we typically call anyways. We usually have covering therapists. So like, hey, I'm going on transport, just so we'll forward our phone so they can cover our other patients in the ICU while we're off the unit. So that's how they typically know we're gone. But communication is key. The nurse will say, hey, we have a transport that was just ordered for a CT. When would be the best time for you to go? Like, there's never a, all right, we're going now, because I might be in the middle of doing a bronchoscopy or something else. So we try to communicate when's the best time to go. If it's stat, it's stat. We just got to drop everything and go. So we try to organize things to where we know that we aren't going to be doing multiple transports where we don't have any accessible if an emergency happens.
And I would add to that, if any of you out there have phone systems that you also share with neither nurse call alarms or patient monitoring alarms going into them, you may need an alternative way to communicate because the phone could be busy for some reason if there's an alert coming in. So it's important to consider, like, do you have a secure texting opportunity if that's something within your phone system, your middleware that could be out there, or your EHRs. All of those have different ways as another option to communicate besides just calling the unit as well. So just keep that in mind.
Okay, we have another question from Michelle about dead zones, such as elevators. Do you have any suggestion on how to handle that?
That is definitely a challenge within elevators, and I would recommend that you would work with your team members from the vendor side for your patient monitoring and your IT professionals. Is it really feasible to somehow put an access point inside the elevator or what. I'm not an expert in that, but I can say here in our experience is that it is a dead zone, but based upon how quickly you can get in and out of there, and will it get picked up right away. And that's what our experience has been. It hasn't been a problem. We also have within our design of our facility a true atrium where it's wide open, so the transport path is part of that. So depending on if you zoom through that, they have the access points at the beginning of that area and at the end. So if you're moving at a quick speed, you're basically covered unless you have to stop right there in the middle, which we did test. So that's part of that testing strategy. When you understand if there's dead zones, how can you work around them as best you can, and what other alternatives do you have in assessing that. Do the best you can from those recommendations.
Okay. Next question here from Rebecca. She was wondering if our policy applies or takes into consideration transporting patients from the ICU to areas such as CT scans or other out-of-unit areas. Have we created a checklist or equipment supplies for safe transport?
We do have some of that. We do have a policy as well as the checklist. I think we're fine-tuning, as you had seen the example of that, and that's one of the things we'd like to roll out in other areas. And I think that within your different institutions, you may have different needs based upon the type of patient. It's certainly a different type of transport for a neonate, for example. We do experience that here, and it's a whole different experience with those going to get the neonate or delivering neonates as it would be within an adult experience. So I think understanding who your patient is and that need is really important, and try to not have too many policies that confuses the stakeholders who are actually at the bedside. They got to keep it simple. So that's one of the things we're striving for here, is to simplify. Sometimes we have too many policies, and in some institutions they could just have one global policy at operational level, or is it just within nursing? We had policies that focus in the ED versus critical care, so we tried to simplify. We had too many policies, so that's one of the things that we're working on now, is how we can keep that simple. So that's something I would recommend. And if you do create a checklist, then if there's a way to automate that, would be nice if that's a possibility. But we've also instituted that quick little checklist within the bag for the cables, because that's our biggest challenge.
Okay, thank you. We have a few more questions coming about transporting BiPAP. I didn't really touch on that. Do you want me to just field this one, or do
Please
you have opinions? Okay. So patients that are on BiPAP, this can be a little tricky because, for one, typically, like the BiPAP vendors at our institution, we use the V60s, which are not, MRI compatible or things like that. We do transport them on BiPAP. If someone is unable to come off, we will transport them on BiPAP. Obviously, you need to know how long those tanks run on your ventilator, because especially if you are on BiPAP at a high FiO2, those tanks go really fast. So you want to make sure that you have enough oxygen for the transport, as well as we've made it just practice. Once we get to where we are, we plug into the wall the hospital's oxygen source, and if the patient is not able to tolerate it laying flat or anything like that, that's when we look at what is the test for, what's the test going to do for the care of the patient, is it going to change our plan of care, and that's what we have to discuss as a team on, is this the best time to be doing this transport on this patient. But typically, if it's just a straight transport of a patient, I started a patient down in emergency room on BiPAP for a COPD exacerbation, then yes, I will go down to the ED, I will pick that patient up on BiPAP, I will transfer them up to the ICU on BiPAP and continue the BiPAP in the ICU until the patient's ready to come off. Let's see here. So Sylvia has a question here about the importance of patient confidentiality. And I was just wondering if you had any insight on how to avoid the general public while doing a transport. As we all know, this is sometimes unavoidable.
Yes, I agree. It is. I've actually been a patient being transported transported and had that happen to me. So it can be a little embarrassing, but in terms of confidentiality, I think that is really helpful to protect our patients in many ways, not only physically that people aren't seeing them, and as well as keeping their data safe. So you always have to have an element of that cybersecurity threat in the background. So what we try to do is just have separate elevators that we are using. We have a designated transport path that's without visitors so that they wouldn't see what's going on. So that really is helpful to have those types of things. And then we ensure that the network that we're running on is also protected from any threat potentials in terms of data not being secure. So those types of things make a difference. I really don't see much of our patients being transported that are in places with visitors, and some places out there may not have that luxury. So you do the best you can to keep that patient safe in terms of their care as well as their privacy.
Okay, we have another question here from Roseanne. She talks about the great information about the equipment and process, but there's little information about the communication report handoff. So her question is, when transferring ICU patients to other departments for procedures such as CT, MRI, surgery, who should be involved in the report, and should the communication tools just be written or verbal?
That's a great question, and I can get back to you on some more details in terms of, I'm not familiar with everything that we do here. I do know that we use, of course, we call each other for report, and then we do something within our electronic medical record as a way to know when we're going to be communicating, or excuse me, when there's going to be a patient that is transferring. But when, for example, when we have a patient in the emergency department that needs to go into ICU, we have an ICU nurse come down to get that patient, and so that's really helpful to be able to do something like that, because they can actually not only have that conversation before they go, but then they can also get eyes on the patient and talk to the caregivers that were down in the ED prior to that transport, and not only exchange equipment, make sure that patient's ready to go for their ticket to ride safely, and then they can work together, and then they get the patient back up. So I think it's a work in progress, and being able to have anything electronic makes things a lot simpler than to have things on paper, and also considering the mobile technology of today, utilizing those mobile devices. If you have the luxury of a phone that is a smartphone within your organization, are there tools within there that could help on the go, being able to communicate and do a checklist that's real simple? And if you were to do it in that manner, it'd have to be very much designed to be like quick check, 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 and what are the most minimal things that you would need to be assured that you are ready. And maybe there's links to things if you need more information. But the communication piece is layered in that not only do you have to have it within written documentation, maybe within the EMR, but also calling each other, just as simple as that. And that's one of the challenges that I know can happen, is if the unit is busy and maybe there's a coat on the unit, or there's, a patient who is getting out of bed and the fall alarm goes off for the bed, things like that can monopolize people's attention as well as their phone. So having that alternate way to communicate and get a hold of each other, either during an emergent or urgent way, is helpful to have a secondary way, either through landline or texting. We're finding we still use pagers, of course, but they're one-way of communicating. So even though you send a page, you may not know if it was received. And one of the things that we're working towards is simplifying that pager message so that that's standardized. Maybe do it like an S-bar really quick so that people know if there's another thing that you needed to talk to, and that's the last resort. So think of things like that. But if we have any other tricks and tools, we can get that to you.
Okay, so we have another question here from Kathleen. Her question is, can transport monitors all be interfaced with Vocera technology so they can be detected and voiced on transport as well as at the bedside?
I don't have an answer for that question, as I'm not familiar with how that works within, your area, you may want to work with, if you have Vocera, to work with them. But my understanding is, as long as that patient monitor is connected to the network, which then would send, let's say, an alert or an alarm to that central station, that would then send it, if you have that integration to the Vocera technology, to a phone. So there should be a path to do that. And then if it was to show that there was an alert or an issue from that patient, the challenge may be, depending on who that alert would go to, if it's not the people that are with that patient, is where is the patient on that journey of that transport. In some facilities, you're able to label your access points if you're using a maybe the network, if Philips provides it, for example, that is their antenna system, they can name each one of those little access points with a location. If you're using a type of wireless system that is more on 802.11, which is what we have here, Wi-Fi, it's a little harder to name them in that regard because they're covering such a wide space. So you're not exactly sure of the location, but you may have an idea of where the last few spots were. So that part can be challenging, but I would definitely encourage that. That's an example of really having a partnership with those vendors to help, solve that for you.
Okay, we have a question from Mariana. She's wondering if you have any input on moving critical patients in isolation.
I think that is very much the challenge because we have, I don't, off the top of my head, besides keeping that patient in the situation where they're have a mask, that's what I've seen. And Tyler, do you have any insight from what your experience has been at the bedside?
Yeah, so this recently, in the past probably year or so, changed. Infection control had revamped what we need to do. We typically, if a patient was on isolation, contact with the, the gowns and whatnot, we would gown up and then transport the patient gowned up to wherever they're going. And we've always thought it was weird. We have this gown on, we're, whatever the patient has, we're just moving around the hospital. So we've actually changed it to where we do not transport the patient. While we're getting the patient ready for transport, we have our whatever the PPE is that is required for the isolation, and before we leave the room, we take it off, and keep your gloves on or whatnot, and we transport the patient through the hospital wherever they need to go, and then once we get to the destination, we put our gowns back on or whatever else is needed. That's for the any patient. Then, as Dr. Whalen said, for any patient that's on airborne or droplet precautions, we typically put the mask on that patient as well as ourselves as we go to the transport. So we have a question from Sherry. How do you decide which patients an RN goes with as opposed to RT or RN and RT? Do we have any guidelines that we can share here? So basically, how do we know who goes on certain transports? I would even throw in, when do we decide MDs go on the transport with us?
Good question. Within the policy, you should have those roles defined and what their requirements are for them and what they're supposed to do. And typically it is the RN and respiratory. You can speak to this, Tyler. My experience has been they get involved if the patient needs to be ventilated. Otherwise,
right, yeah.
You probably don't have to deal with them. And so other than that, the RN's doing that. And if you're lucky enough to get like a med student or a provider to come along with you, that would be great. But typically, like anesthesia is always there when they're bringing back the patients. They're the ones who bring back the patients from the OR. But I don't really see, in my experience, a lot of physicians available to do that, even though we have a lot of them here. It's primarily the RN's job. What I'm finding, though, is, and this may be something to discuss, is on an acute care floor, when you have more than one patient, you could have, 5 to 6 patients. They really want this patient who's new, and they want them to go on a transport, but you also have 4 other patients. So that's where it starts to get tricky, and that who's going to go, and that's maybe when you have to ask a resident or a provider to go do it with you or in lieu of you. So what would your thoughts be on that, Tyler, since you also do this too?
Yeah, it's pretty much as you said. The respiratory therapist, for the most part, doesn't get involved in the transport unless they are vented on BiPAP. We transport patients on OptiFlow, which is a whole nother fiasco because those run through auction pretty quick as well. But typically, other than that, we don't. Sometimes if it's like a code stroke or something like that, we will have physicians actually just come with us so they can see the scan immediately in real time. So if there's like an emergent situation like that, we'll have the physician come as well.
And that's another point I failed to mention, is that in some facilities you may have a critical care outreach team. We have that here, and they do respond to either a code stroke or some kind of change in patient condition. So in the past people called it rapid response, and they find themselves in situations where they're the ones dealing with that transport. And so it is nice if you have identified group that can support those things, and they may be able to help, usually going from an acute care floor to an ICU, and that does relieve the staff a bit on the acute care floor because you still have all your other patients, and then the critical care outreach team can then facilitate that transport, and that's a beautiful thing since they have so much knowledge and expertise, and we really find value in that team here, and we're increasing the membership of our team, and it's just invaluable. So if that's something that you can consider at your facilities, I would strongly encourage that too.
Okay, we have a question from Deb. Just prior to our changes with everyone having the same monitors, had that OR and ICU been sharing any equipment prior to the changes?
Well, they've always tried to share equipment no matter what the patient monitoring vendor was, and we did have a point where we had multiple vendors, and it made it more complex. So in that regard, it was more difficult. They would have to have the right cables to make sure that they had what they needed, because let's just say, for example, in an ICU you had monitor X, but then in the OR you had monitor Z. So you always had to make sure that the X was traveling with that patient, the battery wasn't going to be dead, so that when you came back up into the unit, maybe you chose to remove that patient from the OR monitor, place them on the one that had been sitting in the bed that they came with from the ICU, but be thoughtful that, is the battery still okay to be doing that while you've been in surgery for 4 hours? And then that was one of the things that we optimized, our flow was to really understand what's going to be the easiest point where the patient safely can be converted over to the cables. Maybe you don't do it that way. Maybe you just take them from the OR with anesthesia, with that brand Z, wheel them over to the ICU, and then do the transition of the cables within the ICU environment, so that way it's a little bit more controlled. You are in that safe place within the ICU, and you have all the things that you need. So think about that. If you have 2 different brands of equipment, where's the best place to do a transition? Many times they need to turn over that OR, so they want you to get out of there and possibly just do that within the ICU environment. And we did work through a lot of those scenarios and use that process improvement specialist to map all that out for us, to identify how we were going to handle all the different potential mishaps and equipment challenges that we faced. But if you can have it simplified with having the same type of equipment throughout, and if you are lucky enough to build a new hospital, and where are you going to be placing CAT scan machines? That is amazing if you have that opportunity. In our experience here, we do have one of our CAT scans is very close to our neurosurgery ICU and surgical ICU, so it makes it so easy for us to get back and forth and keep our patients safer. Now, I didn't always have that experience when I was at the bedside. Many times we were traveling a far distance down into the basement, and it caused problems. So that would be another beautiful thing if you could do that.
Okay, I think we have time for one more question. So this is from Elizabeth. She's just asking for any specific recommendation or guidelines for transporting the high-risk airway patient, especially in transferring patient from bed to CT scan table, for example.
Well, I think we can both probably help her with this question.
Yeah.
The first thing I would consider is, understanding how patent that airway is and making sure it's okay, and then get all the monitoring involved that you would need to identify if there was any issue that you would know right away and be prepared to intervene, and assessing, you can't probably over-assess, kind of like that trust but verify throughout that experience, because the airway is so critical. And before you make a move, always assessing and reassessing how that is, and just that if you can have more people to help move that patient potentially. So that would be my insight. But Tyler, what would you say?
Yeah, just to piggyback on that, typically, first of all, I think whoever is at the head of the bed, helping with the airway to transport should be in charge of calling when we are moving. So typically that's me at the head of the bed, and I always say it's on my count, we will move. Patients with the high-risk airway, a lot of times what we'll do is we'll move them halfway, just slowly. Instead of the one big thrust over to the other bed, we'll move halfway. And then readjust and move the rest of the way, just to make sure we're going nice and slow. Someone having a hand on that tube, making sure you're not losing that tube. Don't want to make sure you have enough slack on your ventilator. At times, people, depending if what the vent settings are, you could disconnect from the ventilator real quick to move them over and then hook them back up, just in case there's a risk of the ventilator circuit from tugging and potentially dislodging the airway. That is what we'll do at times if it's really a difficult airway and we don't want any risk and the patient's on low enough vent settings that it's safe to disconnect for a quick second, move them over, and then reconnect them to the ventilator. But my short answer to that is very carefully and slowly.
Very good.
I'd like to thank you very much for your time, both Dr. Whalen, for this informative presentation, and as well to you, Tyler, for being our moderator today. It has been such a pleasure working with you both. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.